Hi, everyone. We're going to give it just another minute so that we can let people filter in. Okay, and while we're waiting, I'm just going to go through a few housekeeping items. So this presentation is being recorded. It's going to be on the Dr. Shar Institute website as usual. It'll be under the webinars tab, and you'll have to log into your experts area account to get access and download your certificate. I'll probably have it posted in about a week. That is dependent on when it gets approved for pre-recorded CEUs, so you can watch it on demand and get your CEUs. So it should be up in a week. You'll get it in the newsletter if you're logging in through the experts area account. Throughout the presentation, if you could please just type your questions in the Q&A box. We'll try to get to them all at the end. And if you have any comments or anything, you can put them in the chat, but try to put the questions in the Q&A box just in case I miss it. I'd like to have everything in one spot. So I'll try to get to everyone's questions. And also, if you have any issues with audio or recording, please put them in the comment box so that we can try to address any sound issues. All right, and with that, I'm going to introduce our speaker, Beth Rosen. So Beth Rosen is a weight-inclusive registered dietitian that specializes in GI nutrition and disordered eating, and she's based in Connecticut. She's been working in this field for over 25 years, so we're very lucky to have her here today. And her real specialty is to help clients find relief from digestive disorders like IBS and SIBO and gastroparesis, celiac disease, reflux, and also sharing her knowledge with other professionals via webinars, seminars, and peer mentoring. She's currently the vice chairperson of the Dietitians in Gluten and Gastrointestinal Diseases subgroup of the Dietitians in Medical Nutrition Therapy Dietetics Practice Group of the Academy of Nutrition and Dietetics. It's a long one. She's also the director of Nutrition and Dietary Services for GI On Demand, which is a partnership between GastroGirl and the American College of Gastroenterology. If you guys have more questions about this, I'll share a link to it, but the goal is really to provide integrative GI virtual care and support to patients, and it's a great platform, so we'll share info about it. She's also designed techniques and programs to empower chronic dieters, disordered eaters, and those in eating disorder recovery to mend their relationship with food and their bodies, and interestingly, specifically with people with GI conditions. So kind of hitting a lot of areas that I know a lot of you are interested in. Beth has written for major online and print media publications like Huffington Post, Very Well Fit, and Fabu Plus magazine, and has appeared as a recurring guest on the Fox 61 morning show in Hartford, Connecticut. You can learn more about Beth and her work on her website, www.bethrosenrd.com. I'll also share that link in the chat so that you can all connect with her if you want. And with that, I'll turn it over to you, Beth.
Thank you, and hi to everybody. I'm going to share my screen so that we can get started. There we go. And thank you for that warm welcome, Megan. I'm just going to shut this window so I don't see myself talking. Today I'm going to be talking about managing GI disorders in your clients who may have eating disorders. And I'm sure you're aware that this is a common occurrence. And my goal today is to give you some tools to be able to help your clients feel good in their bodies as they heal. I have no disclosures to report other than what you heard in my bio. If you'd like to connect with me, let's see if I can get this to advance. Oh, sorry, having trouble with the advancing. There we go. If you'd like to connect with me, you can do so at my website or through Twitter or Instagram is where I tend to hang out. So the objectives today, I hope that you are able to understand the connection between functional GI disorders and eating disorders, recognize the most common GI conditions that clients with eating disorders will present, and begin to apply dietary interventions and some non-dietary tools to improve symptoms associated with GI issues. So let's start with what a functional GI disorder is. So they are a group of disorders classified by GI symptoms related to any combination of motility disturbances, visceral hypersensitivity, altered mucosal and immune function, gut microbiota, and/or central nervous system processing. And that's a quote there. And the difference between functional GI conditions, also called disorders of the gut-brain interaction or DGBIs, And structural GI disorders is that no changes to the structure of the GI tract is happening in a functional GI condition for the most part. So there are no strictures in the intestines, there's no narrowing of the esophagus, there's no polyps in the stomach. Everything that your client is feeling is not due to an altered GI tract for the most part. DGBIs are not diagnoses that are thrown at symptoms when nothing else has been diagnosed yet, and all structural GI conditions have been ruled out. So they're their own class, and they are diagnosed using something called the Rome 4 criteria. And this can be really frustrating to clients who feel like they're not being heard or believed by their healthcare team. And so it's important to explain to our clients that structural GI disorders must be ruled out first before a DGBI can be diagnosed. So for example, ideally, celiac disease would be ruled out before IBS or irritable bowel syndrome is diagnosed, given that they have similar symptoms, but celiac disease, if left untreated, can cause structural damage to the intestines. So what is an eating disorder then? So a simple definition of eating disorders, and we'll go into more depth in a moment about the individual ones, are psychological conditions that result in the alteration or disruption of competent eating behaviors. And the criteria for diagnosing eating disorders are found in what's called the DSM-5, which are criteria used by mental health professionals. They're the ones that do the diagnosing. So RDs and other healthcare professionals don't do the diagnosing, but we may notice the emotional or behavioral or physical changes to our clients while we're doing our assessment. Here are some common emotional and behavioral symptoms of eating disorders that you can include or read into your questions when you have conversations with your client, and look out for these things. So most common would be a preoccupation with food, their weight, calories, whatever the latest diet is. And also you may notice a preoccupation with certain behaviors or attitudes about dieting, like they talk about just for instance, eating clean or favoring a certain famous person's body and wanting to look like that. Refusal to eat certain foods and progressing more to limiting not just foods, but maybe whole food groups. Appearing uncomfortable eating around others, skipping meals, or doing a lot of talking about food. And also a real strong concern with their body size and shape. And the last one here is frequent checking in the mirror for perceived flaws, which is also called body checking. There are also some physical signs that you can see either when you see them or ask about or read about in their history if they were referred to by a physician, if the physician had done some screening themselves. So you might notice noticeable fluctuations in weight, either in their health history or if you know them. You might see that. Menstrual irregularities in those that have a period. There might be dizziness or inability to maintain their body temperature. Some will have dental problems. You might notice thinning of hair, a dulling of the hair, brittle nails as well, and muscle weakness too. Or they may show no signs. So everyone presents their eating disorder in their own individual way. Not every eating disorder will have these. These are just common signs. People with a history of weight cycling or yo-yo dieting may possess maladaptive eating behaviors too, and they may be subclinical for diagnosing an eating disorder, but patients with suspected eating disorders should be referred to a specialist so they can get help for the eating disorder before treating them for the GI issues. So one way to know if they have an eating disorder, if they have not yet been diagnosed or they haven't told you, is to ask some questions. And these 3 screening tools can be a great help for that. So there are many others. This is not a comprehensive list, but the first one is the eating attitudes test known as the EAT-26. There's also the eating disorder examination questionnaire. And this last one here is the celiac disease food attitudes and behavior scale. And this last one is the only one validated for use with people with eating disorder behaviors and GI conditions. So the other 2, while they'll let you know whether or not there are some maladaptive eating behaviors, if they have GI conditions, it can skew the results, and so it may not be clear whether or not they truly have an eating disorder or if they have a GI condition that's just making them miserable with food. I want to briefly introduce some common eating disorders to you. Again, as a dietitian, I cannot diagnose, but I do play, and if you're a dietitian, you play a role in recovery and the decision to recommend a higher level of care. So it's important to know what an active eating disorder looks like. And I want to start with anorexia nervosa, which is typically represented as people in really thin bodies, but people of all sizes can have anorexia. And in fact, less than 6% of people with anorexia have medically diagnosed as underweight. So I want to just say that one more time so you hear it. Less than 6% of people with anorexia are medically diagnosed as underweight. So plenty of folks in bigger bodies have anorexia, and it looks a little like this. So there's that preoccupation with food and dieting and food and parts of foods, a struggle with body image, a resistance to maintain or inability to maintain their natural body size, a poor relationship with exercise, typically abuses it or has a rigid relationship, will use exercise even when they don't feel good. And again, frequently body checking is one of the indicators of anorexia. So bulimia nervosa is the next one. And the most notable indicator for bulimia is purging. And purging can be done via vomiting or by using and abusing laxatives or diuretics. And that's what you might see there. So there's evidence of binge eating and then evidence of purging behaviors, a preoccupation with food. This could be drinking excessive amounts of liquids or making strange recipes or cooking for other people and not eating it. They also tend to have dental problems. You might also see swollen glands or in their neck or in their cheeks from regular vomiting, and if they use and abuse laxatives and diuretics. Binge eating disorder is more common than you might think, and it's estimated that 40% of people seeking weight loss treatment have binge eating disorder. And the biggest difference between binge eating disorder and bulimia is that while they both have binging as part of it, there is no purging with binge eating disorder. So one of the common indicators is secret recurring episodes of binge eating, which looks like eating in a discrete period of time an amount of food that is much larger than most individuals would eat under similar circumstance, usually done with feeling a lack of control over the ability to stop eating or even dissociating while eating. There's a lot of shame and self-blame in binge eating disorder. There's also hiding and stealing of food, tucking it away so that they have it for whenever they have a binge, and also self-medicating with food. So using it as a coping behavior for other emotional feelings. So this one is avoidant restrictive food intake disorder, otherwise known as ARFID, and it's becoming more commonly diagnosed amongst those with GI disorders. And the common indicators for ARFID are that there's little interest in food or an anxiety around the feared foods, a limited range in their food repertoire that becomes more narrow over time, lots of fear of like choking or vomiting or something getting caught in the throat. Weight loss is common in adults, and the inability to gain weight in children is a sign as well. ARFID is different than the other disorders that we've discussed so far, mostly because there's no body image component and there's no fear of weight gain. And we are seeing this a lot in the GI space. Okay, this next one is OSFED, or otherwise specified feeding or eating disorder. And this is the diagnosis that's used when the person's symptoms don't neatly fall into one set of criteria for an eating disorder diagnosis. And here are some common indicators here. So frequent episodes of binging and purging to avoid weight gain, self-esteem overly related to body image that we're seeing, dieting behavior, So reducing the amounts of foods or the types of foods consumed, or following different diets. So going from vegan to vegetarian to keto to paleo and jumping around like that. And of course, abnormal or perceived thoughts about the body that are not necessarily true. The pathology of the connection between DGBIs and eating disorders is only partially understood. So if we start at the top of this vicious circle here in the dark pink, you could see that eating behaviors can impact, or eating disorder behaviors impact the GI tract and can lead to malnutrition and electrolyte imbalance, which in turn can impact the gastric motility and intestinal transit time and slow things down in the gut. And food will sit in the GI tract and produce signals of distension, and maybe that's fermented, and so gas and pain and fullness occur. And then changes to the gut microbiome can happen when all this other cascade happens, and provoke GI symptoms, as well as an inability to regulate hunger and fullness. And so what we do know about this is that functional changes along the gut-brain axis are worsened by changes to the microbiome. So a diverse microbiome is a healthy microbiome, and also from undernutrition. And impaired GI motility appears to be secondary to malnutrition, muscle wasting, and from the lack of neurotransmitters. So for the most part, we tend to see GI conditions in folks with anorexia, bulimia, and binge eating disorders. Folks with ARFID have lower rates of GI co-occurrences. In that case, the GI issue will come first and ARFID might follow after. And in the other cases, the eating disorder starts first and then the GI follows from the eating disorder behaviors. So in ARFID, we see about 30% of folks with GI disorders, as compared to 75% of other eating disorders, compared with anorexia having the highest rate of GI issues. And the difference is believed to be due to the lack of focus on weight for people with ARFID, but more research is definitely needed to be done in this area to determine for certain the cause and the connection between DGBIs and eating disorders. Nevertheless, they will persist in your practice. So here are some common conditions and symptoms you might see in your client population from the GI side. And they include globus, functional heartburn, reflux, rumination, SMA syndrome, which I'll talk a little bit more about, gastric distension, gastroparesis. We also see irritable bowel syndrome, and then your basic gas, bloating, diarrhea, constipation, also ending with pelvic floor dysfunction and rectal prolapse. So I'm going to go through these with you, but I'm just going to go through the most common ones that I see with people with eating disorders. So in the interest of time, I'll just go through those top to bottom, literally. So let's get started with the top. Gastroesophageal reflux disease, otherwise known as GERD or simply reflux, is characterized by a burning chest pain or regurgitation of fluid or food, or the development of inflammation or the sensation of inflammation in the esophagus that leads to swallow dysfunction. Your clients may also experience cough or hoarseness. I tend to see people clearing their throat a lot who have GERD who come to my practice, or they think that they have postnasal drip when in fact it ends up being reflux. So in folks with anorexia, studies have shown that there was a higher rate of GERD-related symptoms than those in the control group. And in bulimia, self-induced vomiting, which makes sense, can lead to reflux, but it rarely leads to structural issues such as mucosal damage, Barrett's esophagus, or cancer. And in folks with binge eating disorder, they may experience a weakening of the lower esophageal sphincter, which is that muscle that separates the stomach from the small intestines. And it can be impacted so that the stomach acid is no longer just staying in the lower esophageal sphincter separates the esophagus from the stomach. And it helps to keep the stomach acid in the stomach and not coming up to the through the esophagus. So the goal of the dietary modification is threefold. So first, we want to reduce mucosal irritation. And the way to do that is to minimize acidic and spicy foods and beverages. And the second way is to preserve that lower esophageal sphincter tone. So we want to minimize the known triggers that can contribute to laxity in that muscle. And they're listed there so you can see them. And we also want to minimize carbonation and eating past fullness, because that will also stretch the sphincter and cause it to weaken. And then the third one is reducing the risk of gastric distension. So, blowing up the stomach with lots of gas from carbonation or eating past fullness can also impact that muscle. But not all of the potential GERD triggers will lead to symptoms in every client. So it's important to work individually and explore with curious observation what might be leading to their symptoms, rather than just removing all of those foods in the list without a reintroduction. So you can use a food and symptom log and have your clients explore the correlation between foods eaten and symptoms felt. And then you can suggest substitutions for those triggers. So for example, coffee is on that list. That tends to be the one that gets my clients all wound up when they see that might be something that causes them trouble. But there are low acid coffees on the market. So I tend to send them links to that so that they can try those. I just saw a story of a cocoa powder coffee drink, which I have to explore more, but I'm hoping that that's low acid too, because I think lots of people would enjoy that. But the goal is for them to find comfort in their bodies. So we hope that they want to diminish those symptoms, but because it's a functional disorder, if they continue to eat those trigger foods, then they're going to feel symptoms, but they're not doing major damage to their bodies for the most part. But if we're teaching them to find self-compassion, especially while they're going through eating disorder recovery too, along with the curious observation, then hopefully they will listen to their bodies and reduce their exposure to food triggers in order to feel better and not feel triggered by the restriction. Again, though, if the restricting the food trigger is leading to eating disorder behaviors, then they can continue to eat those trigger foods, and we can try some behavior modifications instead. So the first behavior modification is to avoid eating past fullness. And the best way to do that is just to divide eating opportunities into smaller opportunities throughout the day. And that's really for people who eat 1 to 2 or 2 to 3 times a day. But when people are in eating disorder recovery, they tend to eat 5 to 6 times a day, if not more. So we want to make sure that they realize that they have permission to eat as often as they feel hungry and according to their meal plan. Maintaining an upright position after eating, and even taking a light walk after eating, the gravitational pull of that will help to move the food, lower into the stomach and away from the lower esophageal sphincter to help them feel comfortable. Elevating the head of bed as they sleep can help reduce regurgitation overnight. They can use books under the head of the bed, or even wedge pillows can be purchased. And then the last one here is to avoid tight clothing around the stomach, because that squeezing can always trigger if it's squeezing real hard. So I tend to have my clients avoid things like Spanx or really tight elastic waist yoga pants. Okay, so this next condition you may see is called superior mesenteric artery syndrome, or SMA syndrome. And this is typically seen in folks that have lost a lot of weight quickly. And the SMA is a superior mesenteric artery. So if you look at that bottom left picture, it's the branch coming off, not the main one, but the branch coming off. And that is held in place with mesenteric fat that allows the duodenum to pass underneath it. So it has, a great role there to take care of our digestive system by lifting up that really heavy artery. And when the fat is lost, though, the heavy artery compresses the duodenum and leads to symptoms that include loss of appetite, abdominal pain, postprandial distension, early satiety, nausea, and vomiting. And without a diagnosis, bowel obstruction can occur, depending on what they're eating, along with food fear to the pain that accompanies it. And also food avoidance can happen, which can make nutrition rehabilitation and eating disorder recovery really a challenge. So I see the pain that these folks are feeling, usually while they're eating or immediately after, since the artery is not allowing the stomach to empty into the duodenum effectively and fully. The dietary modifications include GI soft texture diet, and that's things that would easily pass through, a smushed duodenum. So soups, pureed foods, soft cooked vegetables, not whole fruits, but smoothies instead, not whole nuts, but nuts instead, nut butters instead, things that are smooth like yogurt and cottage cheese, those kinds of things. And also small frequent meals to ensure that they're getting enough nutrition and that they are gaining weight so that their bodies will reposition the artery and decompress the duodenum. I see a lot of gastroparesis or delayed gastric emptying secondary to eating disorders in my practice, and it's defined as delayed gastric emptying into the duodenum in the absence of a physical obstruction. And this is diagnosed by a gastroenterologist using a gastric emptying test called a scintigraphy. And your client will spend a few hours in an office or special lab. They'll have to eat an egg sandwich with a small amount of radioactive material. And then a special camera is used every hour for 3 or 4 hours to measure where the food is in the digestive tract and how long it takes to leave the stomach. The sandwich itself can be challenging for some who are in eating disorder recovery. So it's good to know what the test is about so that you can prepare them and maybe practice eating eggs or eating sandwiches, because that's something they'll have to do for this test. Symptoms include postprandial fullness, early satiety, nausea, vomiting, and abdominal pain. And these symptoms will persist or worsen throughout the day as more food is consumed. So you can imagine feeling stuffed and uncomfortable all day can be a barrier to treating the eating disorder when food is causing pain. The good news is that when nutrition rehabilitation begins, it's possible to see significant improvement in symptoms within 4 months of starting the nutrition rehabilitation. And one study had talked about the diameter of the antrum, or the narrow portion of the bottom of the stomach, relaxing or opening up. So that part is structural, but it's due to a functional disorder. But even after the physical changes take place, like the loosening of that part of the stomach, the hypersensitivity to pain and the discomfort can remain for many with eating disorders, most likely due to somatization and visceral hypersensitivity, which makes recovery a challenge. And that's all part of that miscommunication between the gut and the brain with functional GI disorders. The dietary intervention for gastroparesis is small frequent meals as often as they can eat, and chewing well, because digestion does begin in the mouth. Having fork mashable foods, eating things that are about the size of a grain of rice, limiting fiber particle size of intake. So this is a low fiber diet, but fiber will be consumed. So low fiber is considered 15 grams or less. So there will be fiber. And the best way to intake that is, to really puree it so that the stomach doesn't have to work so hard to break it down, to make it, to break it down to smaller bits, the food down to smaller bits. So limiting fat intake also is part of this, which we do because it slows digestion, and digestion's already slowed. But liquid fats are more easily digested than solid fats. So you can always recommend using a little olive oil and building on that as time goes on. We want them also to consume beverages between meals or after meals so that they don't fill the stomach with liquid, and also consider supplemental nutrition beverages, because every bit of fluid is going to be good fluid, but we also want to make sure that there's energy associated with that fluid. So drinking juice or smoothies is a better choice sometimes than water or coffee. So irritable bowel syndrome is this next one. And this is the most common GI disorder amongst those with eating disorders, with 41 to 52% of people with eating disorders having IBS. So that's a lot of people. Also notably, 68% of people with bulimia have been diagnosed with IBS. And so I'm going to spend the most amount of time on IBS so that you'll know best how to help these clients. So IBS is diagnosed via 3 criteria, which are related to defecation, changes in bowel habits, and a change in the consistency or its appearance. And there are 4 subtypes of IBS that are determined by how frequently a patient experiences very hard or very soft stools. And the 4 subtypes are IBS with predominant constipation, IBS with predominant diarrhea, IBS with mixed bowel habits, and IBS unclassified. So the way that this is done is that it's based on days with at least 1 abnormal bowel movement, and the predominant experience makes up at least 25% of bowel movements. And the determination shouldn't be done while someone's on a medication that impact bowel habits. So if they are working on getting classified as what they have, they'd have to go off something like Miralax or Imodium to determine what their bowel habits actually are. There are a few options for dietary modifications for IBS. The first is the low FODMAP diet, which includes 3 phases. The first being an elimination phase where highly fermentable carbohydrates are removed from the diet for a short period of time and then systematically reintroduced to determine an individual's food triggers, if any. So the limitation here is that the diet can be very restrictive for those who have an active eating disorder. The pro of this diet is that it can actually liberalize a restricted diet by providing a safe space, so low FODMAP options from every food category that are known not to cause symptoms. But the creators of this intervention have stated that this diet is not appropriate for people with active eating disorders. So there's also the FODMAP Gentle, which is a 3-phase diet also. It's just removing the most common high FODMAP foods that have been seen in research over the past dozen years. And that's more appropriate for people in recovery. And I'll show you what these look like. So just a brief overview of the low FODMAP diet. It gets a bad rap because many people who are undiagnosed with or untreated for the eating disorder will go to a gastroenterologist with their GI condition, and they'll be given, a 1-page handout or told to follow the diet and not screened for their eating disorder. And so that can also add to their eating disorder. So again, it's not for everyone, but I just want you to understand the basics in case it's an appropriate tool for your clients. So the first phase of the low FODMAP diet is the elimination phase. And the goal here is to remove all possible fermentable and non-absorbable short chain carbohydrates. It's not intuitive, so they do need to be taught which foods are safe during the elimination phase, and so it should be administered by a GI dietitian. Also because the science is ever changing, the research is ongoing, and there's new information all the time. So a 1-page handout is typically obsolete by the time it's printed. And if it doesn't work within the first 2 weeks, we stop the diet. If it shows to be helpful within the first 2 weeks, then we can move on to the reintroduction phase. And this is where our goal is to really liberalize the diet, to increase variety of choice, reduce food restriction and fear, and minimize the risk of developing any further maladaptive eating behavior. So there are some people who will say, I feel so good on the elimination phase, I just want to stay on this. Well, we know after 3 months that this can impact the microbiome, and we know a diverse microbiome is a healthy microbiome, so we don't want that to happen. And we also don't want to perpetuate any poor eating habits. We want to liberalize the diet. That's the other goal. So there is a systematic way to reintroduce foods one at a time to test. But if a food is unsuccessfully reintroduced, that's not something they avoid for life. In the next 3 to 6 months, they can try it again and continue that way. And the last phase is the personalization phase. And this is where they eat the low FODMAP diet plus the successfully reintroduced foods in order to avoid symptoms. Again, this is a functional GI condition. If they want to eat a food that is a known trigger for them, that's okay. Nothing's going to happen except for symptoms. They're not, causing damage to their bodies. But it's important during this time for them to move on to the personalization phase, because it empowers them to know what foods, if any, are causing their symptoms, and to understand when food is not playing a role, right? Because we know that this is miscommunication between the gut and the brain. So it's possible that lack of sleep or stress management, poor stress management, is contributing to symptoms as well. Okay, so this is what the FODMAP Gentle looks like. And this is a great option for people who have gone through eating disorder recovery and are looking to remove the possible food triggers if they think they still have them. So these are just the few foods that get removed. And the last intervention that it could be helpful is something called that's been coined by a dietitian. Her name is Patsy Katsos, a GI dietitian. It's called cherry picking. So as the dietitian going through their list of foods or what they've been eating and noting when you see a high FODMAP food and maybe suggesting, hey, instead of asparagus this week, do you want to try broccoli? And without them even knowing that you're removing a high FODMAP food, you can see if they start to feel better. So there are also some non-dietary modifications that you can try. And the first one is prebiotics. And prebiotics are the fuel or the food source for microbes in our gut. And they're sugars and fibers found in fruits and vegetables and whole grains and beans and nuts and legumes. And these prebiotic fibers are not digested in humans, but they make their way to our large intestines where our microbiota ferment them and they flourish. And in a study comparing prebiotics in the form of a supplement to the low FODMAP diet, researchers concluded that after 4 weeks, both groups had statistically significant reductions in all symptom scores, except reductions in flatulence and bowel sounds in the prebiotic group. They suggested that intermittent prebiotic use, so maybe 1 month on, 1 month off, may help with functional gut symptoms, most likely due to a non-diversified microbiome. And then the most effective prebiotic supplement that would work for this is partially hydrolyzed guar gum. It's slow to ferment, so it's a low FODMAP fiber, and it's what they used in the studies that they've done so far. Another non-dietary tool is something called gut-directed hypnotherapy. And this has been shown to improve quality of life and IBS symptoms. And it targets psychological coping, central nervous system processing, and gut-brain interaction. And studies have also demonstrated the effects on intestinal transit time and the mucosal immune system. So, but unlike prebiotics, gut-directed hypnotherapy does not have an impact on the microbiome. And in one study, there were 3 groups as part of this intervention that were in a trial for 6 weeks and then follow up at 6 months. And one group was on a low FODMAP diet, one group received gut-directed hypnotherapy, and one group received both low FODMAP diet and gut-directed hypnotherapy. And GI symptoms and quality of life were assessed in all groups, both pre-intervention, post-intervention, and at the 6-month mark. And there was no statistical difference between the groups when looking at GI symptoms. Both were effective, but there was an advantage to the hypnotherapy on psychological indices, statistically significant for reducing anxiety and depression at the 6-month mark. So this could be a really good tool as an alternative if diet is not appropriate. Okay, so here's some non-dietary modifications, which are supplements and enzymes. Enteric-coated peppermint oil acts as an antispasmodic in the gut and can help reduce urgency and may play a role in managing bloating. And the way this is taken is 3 times a day, 1 capsule before each meal. And chewable simethicone in combination with antispasmodics, so maybe with the peppermint oil, has shown improved impacts on symptoms than the antispasmodic alone. So it's a great helper. Chewable simethicone helps to break down gas bubbles, so a lot of my clients just carry them with them, and there might be a placebo effect or a nocebo effect, but they're harmless and seem to be helpful. And then in order to liberalize the diet even further, sometimes enzymatic supplements can be used. So the two that are most notably effective are lactase, which helps to break down the carbohydrates in dairy, and taking 9,000 units with the first bite of food will give you about 45 minutes. So if you are eating out and having an appetizer that has dairy and a dessert that has dairy, you might want to take it twice, but it's relatively inexpensive. And the other one is alpha galactosidase, say that one 3 times fast. And that one is found in Beano, but there are other brands, and it breaks down it's an enzyme that works on the carbohydrates in beans and legumes. Other non-dietary modifications can include a toileting regimen for those with IBS constipation. So drinking a warm or hot liquid in the morning can stimulate the gastrocolic effect and lead to a bowel movement. Also, prioritizing bowel movement time, so setting some time aside after drinking the warm liquid and going to sit in the bathroom for 5 to 10 minutes can be helpful to get the body used to it. Also, body positioning, or toileting positioning. So having your knees positioned higher than your hips by using a squatty potty or a stool or yoga blocks can allow the pelvic floor muscles to relax and allow for passage of stool. In addition to that, you can use psyllium husk and kiwi fruit. Both of those have been shown to alleviate constipation without any gas or bloating. So there was a study that showed a comparison between psyllium husk, kiwi fruit, and prunes. And as you can guess, prunes had a laxative effect and lost the race, but these two did pretty well. And for those with IBS, an osmotic laxative, so different than a laxative that causes spasms or contractions or stimulates like artificial peristalsis, these types of laxatives draw colonic water into the stool to bulk it, and that signals the intestines by stretching it to stimulate peristalsis in the gut, which is how it should be working. There are also some prescription medications, but in the interest of time and because I can't prescribe them, I'm just going to pass over that for now. Okay, so I want to take a minute to talk about small intestinal bacterial overgrowth, or SIBO, even though there isn't an evidence-based dietary intervention for it yet. But per the American College of Gastroenterology, SIBO is defined as the presence of excessive numbers of bacteria. We also know it's not just bacteria, it's also methanogens in the small bowel, causing gastrointestinal symptoms. And these bacteria are usually coliform, which are supposed to be in the colon, and they ferment carbohydrates, the FODMAPs, and produce gas, which lead to symptoms including bloating above the umbilicus. So I'll ask my clients when they say they're bloated, do you feel it above your belly button or below? And if it's above, then that's sort of a sign to me that there may be some SIBO there. But there's also gas, diarrhea, and in some cases, villus atrophy in the small intestines. But you would only see that when it's diagnosed. So there are 2 ways to diagnose SIBO. One is through a duodenal jejunal aspirate, and then there's a cutoff of 10 to the 3rd power of colony forming units per milliliter. And there's a limitation to that because there's, the sampling errors could be off, and only a small part of the small bowel may be aspirated. A more common diagnostic tool for SIBO is a breath test with a fixed quantity of a carbohydrate substrate, either glucose or lactulose. And this method is also limited because not all labs currently test for all 3 gases that might be elevated. And there's also limitations that exist for each substrate. So with lactulose breath test, you can have a high false positive because of accelerated transit time and colonic fermentation in some individuals. But glucose also has its limitations because it's absorbed in the proximal duodenum, and there can be a low sensitivity for detecting distal SIBO. So it really it's really a limited test, but it's all we have right now. So while there's no data currently that directly links eating disorders with SIBO, there are a number of risk factors such as abnormal motility, low gastric acid, and digestive enzyme composition that could be seen in eating disorders as well. The other risk factors are for SIBO, but not necessarily seen in eating disorders. And the reason why I share this GI condition is that it's commonly linked with IBS. So in a meta-analysis of 25 studies with over 3,000 patients with IBS and about 3,300 controls, found that SIBO prevalence in patients with IBS was significantly increased compared with controls at about 3.7 times greater. And in studies using only healthy controls with no SIBO and no IBS, the SIBO patients were 4.9 times more likely to have IBS. So that's a pretty common connection there. And then in 7 studies of patients with IBS and SIBO, antibiotics relieve symptoms in 81.6% of patients. And that is currently the first line of treatment. But please note that the quality of evidence of these studies is still low due to the lack of uniform selection criteria for participants and the limited sensitivity and specificity for the breath tests themselves. Dietary modifications have little evidence to support a significant benefit with SIBO, but because IBS and SIBO have been linked, many times the low FODMAP diet does help. So the goal of dietary modifications is really the same as it would be for IBS or many of the others, right? So helping to manage GI symptoms, help maintain a healthy food relationship, correct nutrient deficiencies, and screen for maladaptive eating behaviors and food fears. The other thing to note is that the goal of the behavior modification, which would be meal spacing or using prokinetic drugs, is to increase what's called the migrating motor complex waves. So during periods of fasting, the migrating motor complex, or MMC, in the small intestine is this wave-like cleansing motion that comes every 90 to 120 minutes after all the contents in the small intestine move on to the large intestine. So meal spacing may be beneficial to allow for more frequent MMC waves, but I always recommend that people eat according to their meal plan or listen to their hunger cues, because we don't want to cause any more restriction in those patients. So the next condition I want to talk about is constipation, which is not just about moving bowels infrequently. It includes a number of symptoms such as excessive straining, a sense of incomplete evacuation, failed or lengthy attempts to defecate, and abdominal bloating, hard stools, all of those things. And possible causes include IBS with constipation, but there are other causes as well, such as colonic hypomotility, which causes a slow transit constipation, and that can be related to malnutrition, and also pelvic floor dysfunction. So there's a few kinds of pelvic floor dysfunction. One is dyssynergia, which is an impaired coordination of muscles that obstruct the ability for the stool's passage. That squatty potty or knees above the hips sometimes helps with that. There may also be a high anal resting tone or laxity in the anal tone, which can impact either the inability to relax the pelvic floor or the inability to actually push the stool out. And then the last one here is abdominophrenic dyssynergia, or APD, which is where the muscles that are usually part of moving food along in the abdominal wall are not coordinated anymore, and they can cause distension. So these are the people you see who say to you, I'm 9 months pregnant, I look 9 months pregnant, and that's typically that kind of pelvic floor dysfunction. So I want to focus on that for just a minute because it's common, but it is underdiagnosed. And your client may think the constipation is related to what they're eating rather than a muscle coordination issue. So some of the signs of this are very infrequent bowel movements, like less than once a week, straining even when their stool is soft, the constipation not responding to a high fiber diet, or even feelings of exacerbated symptoms with fiber supplementation, having to contort the body to expel gas, or pressure in the bladder and painful intercourse. So there are some ways to treat pelvic floor dysfunction. very similar to superior mesenteric artery syndrome and gastroparesis. Soft foods, low fiber, we just want to reduce the fiber burden. And then behavior modifications, changing toileting position, as we talked about before, something called splinting. So if your client has a vagina, they can insert a finger and support the perineum or the back wall of the vagina while moving the bowels. That could be helpful. And also referring out to a GI for a diagnosis so that your client can also get what's called pelvic floor dysfunction. Not pelvic floor dysfunction, pelvic floor physical therapy. Okay, so just in a minute, I'm going to wrap up here, but I just want to share some clinical approaches to managing GI disorders with eating disorder clients. And first, we want to make sure that when they present with symptoms, that we want to make sure that it's coming from a relevant, objective place. So we want to know that they've been to a gastroenterologist, and if not, we refer out. That they've been tested, that they have their test results, and they can share them with us so that we know how best to treat them. In addition, we want to also address any non-evidence-based diagnoses or any diets that they're following that are not science-based. So, food sensitivity testing or GI mapping, or if they're treating their own leaky gut syndrome or candida, or if they've had MRT or LEEP testing, which is not currently considered evidence-based. And then maybe most importantly is adding GI-related practitioners to your team to support your client when appropriate. And here's a list of them. And if you are not a dietitian who is well-schooled in eating disorders, I would refer out to help them as well. And you can take a screenshot of this if you'd like. Here are some directories to help you find people, practitioners who do gut-directed hypnotherapy, GI psychologists. I was just told recently that there are 400 GI psychologists worldwide, so you might not find one in your area, but I believe that will be building. And then you can find a pelvic floor therapist. They're different than regular therapists, physical therapists, at this link here. And to find a GI dietitian, if you are not one or don't know of one, you can go to the directory at the International Foundation for Gastrointestinal Disorders, or to Kate Scarlatta's website. She is a well-known GI dietitian who vets all of her dietitians on her list. And that is it for me. I want to say thank you to you for listening, and happy to take any questions.
Yeah, so we have some good ones, so I'm glad we have time. So the first one is, what are your thoughts on set point theory?
So set point theory is, I touched something. Set point theory, for those that don't know, is where our bodies really like to be in homeostasis or in balance. And so there's a weight range where our bodies fall naturally. And that's what I might have referred to earlier as your natural size. And so when people restrict their food, or that they have an eating disorder, they may be, pulling themselves down in their weight. But what will happen then is that they'll slow their metabolism because of that restriction. And so when their body finally signals them to start eating again, they'll gain that weight back. And for 1 to 2/3 of folks, they'll gain more than they started. So you can actually reset your set point weight range depending on how often or how much you've dieted in your life. So our bodies really don't agree with the common theory that bodies should all be small and the same.
Yeah, thank you. So we have a lot of questions specifically about eating disorders, so I'm going to group them together. So how do you know if restricting foods will be triggering? And what about asking patients to track their food? What is the best way to know if this is appropriate or not in this population?
Yeah, I would say ask them, right? Everybody's an individual. Ask them what they're comfortable with. Meet them where they are. So, if they don't want to keep a food log because that feels diety to them or it brings them back to their eating disorder, ask them when they have symptoms, maybe just write down what they had in the last, 24 hours, and only write it down so that you can look at it together and see if food was an issue. And that could be helpful. But if I'm asking people to keep a food diary, I'm making sure that they're doing so in a place that's safe for their eating disorder, meaning that there's no calories being counted, no macros being counted. So I will use a couple of apps. One is called Rise Up and Recover. Another one is called Recovery Record. And then even in the Monash FODMAP app, there's a diary in there that doesn't count anything. So that's a safe place for them to keep a symptom record too. And, you know, good old-fashioned notebook works well too.
Yeah, and similarly to that, I've avoided having my eating disorder patients keep food logs, but I can see how identifying GI symptoms related to foods can be helpful for determining and treating the disorder. So how do you recommend using the logs as to not trigger? I think you sort of answered that with, you know, not asking for any macronutrients, but if you just want to expand upon it and maybe mention those apps again.
Yeah. So one of the things that I'll do is I'll say to clients, I'm not going to look at your log when we're talking about GI issues. I'm not going to look at your log, it's yours. And that takes away some of the shame they may feel about food judging, which I don't do in my practice, and hopefully other dietitians don't do either. But I want them to be able to look and be critical thinkers and find insights. So maybe they'll see a pattern. When I eat this food on these 3 days, I have the same symptoms. So maybe it's that food. So they'll know. And again, the best way to track is using Recovery Record or Rise Up and Recover, or even the Monash app.
Great. So we have actually a lot of really good questions. So Beth, if you don't mind sticking on a couple minutes late,
Sure.
I think we'll want to get to these. Okay, so is it appropriate to recommend supplements and enzymes to patients with an eating disorder or patients in recovery?
Sure. There's no, you know, if we want to liberalize their diet as much as possible, then enzyme supplementation could be helpful to allow people to eat things that their bodies may not be able to digest while they're, while their body's not working well, while the GI system isn't working well. So I don't think there's anything wrong with doing that. Once we develop a relationship with them, I don't think having a new client come in and saying, oh, you have an eating disorder, you need to take this and this and this and this, right? Because then they walk out with a tote bag full of supplements that they might not need. Instead, you know, if they say, oh, when I have this food, I don't feel so good. Well, if there's an enzyme for that, so well, maybe you could try this. Let's see if you can digest it. Or, you know, for instance, like lactose seems to be one of those things that's really hard to digest. So offering a lactase supplementation or lactose-free dairy products, those both can be helpful.
Yeah, great. And this one's a little bit more specific. Do you find galactosidase to be helpful with whole grain intake?
I don't. I find it mostly with beans. So there are two kinds of, when we look at FODMAP, the oligosaccharides, there are two different like subcategories. There's your fructans and your fructooligosaccharides or your galacto-oligosaccharides. They work with the galacto-oligosaccharides, but not so much the fructans. And fructans are in the grains.
Great. Okay. So what do you do if a patient doesn't acknowledge an eating disorder or even denies one, but exhibits signs and symptoms of disordered eating while you work through GI symptoms together? Do you address your concerns?
I do. I address my concerns, but also when I first start with a patient, I'm screening them before I even start with them. So I get answers to those questions. I find out if they're seeing a therapist, if they've been to the GI doctor before they even start working with me. So as we start to work through what might be causing their symptoms, I might address, well, you don't eat enough, or you're not eating frequently enough. And let's see what the answer is with that, right? It might be, well, I don't want to, or I'm trying to lose weight, or, you know, I'm scared to do that. And then we can develop a rapport and have more conversations and hopefully get them to a therapist to be screened and to be diagnosed.
Great. And this is from someone who says they have to run. So how do you keep volume at each meal and snack low when the patient needs to gain weight and we're working to get more than 3,200 calories a day?
Would that be specifically for somebody with gastroparesis? Keeping the volume low?
Not specified, but it came in kind of around the end of the presentation, so I'm wondering if it was part of the gastroparesis conversation.
Yeah. So gastroparesis is not a static illness. meaning that there are some days when they're going to feel good and they can eat and they don't have symptoms, and other days where they have symptoms. And so what I would tell them is, on the days when you have symptoms, do the best you can, eat as frequently as you can, use nutrition supplemental beverages if you have to, try purees and puddings and things like that. But on days when you feel good, try to eat the sandwich, try to have a regular full-size meal and see if you can tolerate it. And that will help with the weight gain.
Okay, great. And I think this is a good one to end on. So have you always worked in private practice? And if not, how did you handle conversations with patients and clients, maybe even with doctors too, if you were working with them directly, who are hearing from physicians and other providers that the need for weight loss for certain conditions like GERD? How do you handle those conversations? I guess, yeah, patient and physicians and other providers.
Yeah. I like to have a conversation around what would they offer someone in a smaller body with the same condition. So if you're not offering weight loss to someone in a smaller body, what are you offering them to heal their reflux? And I'll give an example. A few years ago, I went to the Digestive Disease Week, and a doctor was giving a presentation about reflux and had said the answer to reflux is bariatric surgery. And I stood up to ask the question that, so if amputating the stomach is the answer, what do you do for the thin people? Do you offer bariatric surgery for thin people? And he said, well, no. I said, well, they have reflux too. So I like to sort of remind people that body diversity exists, and to treat all patients by their diagnosis and not by their body size.
Great. So that covers all of our questions. Beth, thank you so much for being here and sharing your expertise with us. A few people asked for the references, so if you could send me your reference list, we'll get that out
Sure.
to everyone who is interested in learning more. And everyone, you will probably be getting an email from me tomorrow with your certificate of participation for your CEUs. And the link to the recording, like I said at the beginning, will probably get sent out sometime next week. So you probably get multiple emails from me, but if you have any questions, feel free to contact me. And thank you so much again, Beth.
My pleasure.